So maybe the first question would be, in patients that you feel are more suitable for surgical intervention, maybe right off the bat, such as the ones that have ventral CSF leaks or CSF venous fistulas, do you still think that it's worthwhile patching those patients? And what has your experience been in terms of the success rates for those cases?
Yeah, I think so. Patients who come in through our ER or our local with ventral leaks, just with a routine high volume 2-level blood patch, if you get them early on, like within weeks, right, within 2-3 months, maybe 6 months, I think there's a really good chance of fixing that. I think if it's been more than 3 or 6 months and it's a ventral leak, we don't really advocate for any sort of percutaneous treatment. And I think the reason is that there's been some a modification of the tear. It won't really heal anymore with time. It becomes epithelialized more. So that's in addition to having a little bony spur. So even if you have a big bony spur, big osteophyte, but you get to that leak early on, there's a really good chance of sealing that.
Okay, excellent. Thank you. The other interesting question that's come up is what leak type is the most common that you see after sports injuries, such as golf, for example? And is there a correlated location for the leak typically in those cases?
With golf, yeah. I don't play golf, but yeah, we've seen a few patients who get it after playing golf or any sort of sports activity. And I think that's more common to have a ventral or lateral tear in those patients. Part of that is that that patient population skews a little bit younger. The patient population of meningeal diverticula or CSF venous fistulas skews a little bit towards the older population.
Okay, excellent. Thank you. The next question is, do you see differences between iatrogenic and spontaneous spinal CSF leaks? For example, do they look different on surgery, or is there any way to tell the differences?
Yeah, they look very different because the iatrogenic leaks are either leaks that are caused during spine surgery. So then it's usually like a little flap that was caused by the surgeon's instrument. That's usually more acute, right? They'll recognize it at the time of surgery. Or if it's from a lumbar puncture, then you can see like a little pseudomeningeus, like Dr. Carroll showed you earlier. Or if it's in the ventral, if it went through the ventral dura, it's not so much a tear, it's really more of a perfect little circular dural defect. Gunshot wounds, of course, are very different. Those can be, very, very difficult to deal with. But even those usually get better. I just put some artificial dura over it. Don't even attempt to suture it because it's such a devastating injury. I put them on high-dose Diamox for a few weeks, and the combination of that seems to, help seal those leaks.
Okay, excellent. Thank you. Another common question that's come up is for patients that have had multiple blood patches and receive temporary improvement, what would be your suggestion as kind of the next step in their management? So multiple blood patches that do provide relief, but the relief is only temporary.
Yeah, I mean, I think that really depends on the situation, right? So if you have somebody who has an identifiable leak, right? So one of the 3 different types of leaks, then you can go to fibrin glue. Again, it depends on the timing of the leak. And if that doesn't work, do surgery. If you're more talking about somebody who has epidural blood patching done, doesn't cure them, and all the scans are normal, right? Brain MRI is normal, spine MRI is normal, then it becomes, more difficult. Sometimes we do this dural reduction surgery. The success rate of that is not particularly high. We recently looked at 60 patients who we examined with DSMs, 60 patients who had normal brain MRI, no leak on a CT myelogram or an MRI myelogram. And we found CSF venous fistulas in 6 out of those 60 patients. Coincidentally, half of those 60 patients had meningeal diverticula, and the other half did not have any. And we only found CSF venous fistulas in those who had meningeal diverticula.
Okay, excellent. Another question that's come up is, I guess there's some confusion about patients that have had surgery in the spine in the past, and whether it would be okay or fine to go back in the area of the surgical bed and potentially provide a blood patch, or should those areas be avoided?
Yeah, it really depends on the type of surgery. I think I agree really with one of the previous speakers. It's difficult to do blood patching where there's been an extensive laminectomy or spinal surgery. If there is a leak from previous spinal surgery, right, what we call a pseudomeningocele, so there's a fluid collection, then you can place a needle in it, aspirate the fluid, and then place glue where you think the hole is. And I think the group from Duke looked at that a few years ago, and I forget exactly what it was, but they thought if the dural defect is smaller than 3 or 5 millimeters, then you can most of the time successfully treat that with glue. If it's larger than that, then the patient will most likely end up with surgery.
Okay, excellent, thank you. And a related question that's come up as well is that if patients have arachnoditis, adhesive arachnoditis from past surgery or other interventions, would you recommend that they proceed with additional interventions, or would you have any other recommendations?
Yeah, I think if somebody is symptomatic from a leak, whether or not they have arachnoiditis, shouldn't really influence your decision too much, because if it's the only thing that we can offer, then I think it's reasonable to do that. I mean, most patients I see with arachnoiditis have absolutely no symptoms from that. Sometimes people say, well, I have arachnoiditis. Will you make sure that whoever does the blood patching or glue, is extra careful? That doesn't make that much sense to me. It's like, when we do surgery, we think everybody might have some infectious disease in their blood, right? We don't check everybody for HIV anymore, because you're always extra careful. So that really shouldn't influence that decision too much, or it shouldn't really influence on how you perform the percutaneous procedure.
Okay, excellent, thank you. And I think we'll just go with one more last question, which is a patient who's mentioning that imaging has been normal, including brain MRI, full spine MRI, and a CT myelogram. And there's been no response to a lumbar blood patch. Opening pressure was 12. What would be your recommendation as kind of next steps in management?
Well, in that circumstance, I usually, have a discussion with the patient's headache doctor to see if there's anything that can be offered, that's not too high risk. I think sort of the ultimate test to see if somebody is symptomatic or if somebody has symptoms of a leak is to do an intrathecal saline infusion, where a person is admitted to the hospital for a few days, and we place a lumbar catheter. It's done by the neuroradiologist, and we hook up that catheter to an infusion pump. We start at a pretty low rate, and then we go up every maybe 2-3 times a day, just to see if the person feels better. It's a diagnostic test. It's not a therapeutic type of regimen. And then if somebody says at a certain infusion rate, it's like night and day, then I think that proves that they are low on spinal fluid. You might think that there's a lot of placebo in that. I think there isn't that much of a placebo effect. And there are a lot of patients who really believe they have a leak, and we do this infusion test, they're not any better. And, that's always disappointing, but there also is some positive to it in that, then that patient can sort of put that behind them and, look for other answers for their symptoms.
Mm-hmm. Excellent. Okay. So there are a few more questions, but I think just for time purposes, I think I'll stop here. Dr. Schievink, thank you so much.